Så kan jeg starte. Så er vi live om cirka 5 sekunder.
And welcome back to the studio here at the European Pain Congress. I'm here in the studio now with Professor Henrik Vægter from Denmark, who I've been chasing for the last 3 days and finally got him of a networking reception just across the road here, which is why he and I will be sharing a glass of cava during this talk. So cheers, Henrik.
Cheers. Thanks
Good
for
to
having
have
me.
you here.
Yeah, thanks for having me.
Henrik, would you start out by telling me and whoever's listening a little bit about yourself?
Yeah, I'm originally trained as a physiotherapist in 2004 and did quite a lot of clinical work for a couple of years before I got into the pain field and the interest in pain. I did a master's degree from Edinburgh in 2008 in pain management and followed up with a PhD from Aalborg University, where I started having my interest in exercise and pain. Now I have a position as an associate professor at the University of Southern Denmark and at the pain center at the University Hospital of Odense.
So your work is primarily as a researcher,
Yeah.
but the research you're doing is on what we would call real patients. So these are patients who come into a university clinic with multiple disciplines, and you have the opportunity to do research with them. Would you start to introduce us to some of the techniques you use? So how do you research? What is that all about?
Yeah, so there are different areas that I do my research on. So one of them is the effect of exercise on pain, and that is in humans. So it can be in pain-free individuals, but it's also in patients with chronic pain.
And if there was a patient with chronic pain, that could that be fibromyalgia?
Yeah.
So if you have a patient with fibromyalgia and you want to do research on exercise, how could you explain to us what would happen?
Yeah, so the approach we have in the pain center is more an experimental approach. So we try to assess how the patient would perceive different forms of stimulation. So that could be pressure pain or heat pain. So that would typically be the way we would measure the effect of exercise. So we would invite them into the laboratory and do specific assessments with pressure, for example, and then they would be doing different exercises. And
so you would say to the patient, "Welcome to the study," and you would do something to them that is painful.
Yeah.
And then you would quantify that stimulus. That could be like a pressure.
Yeah.
And you would read how much pressure does it take maybe to be painful.
Yeah, or how much they can endure,
or how much they can endure.
Yeah.
And then I guess that's sort of a baseline or a starting point.
Yeah.
And what would you do then to study the effect of exercise?
Yeah, then they would be performing a specific exercise. So that could be a bicycling exercise, it could be a muscle contraction exercise, and then we would measure pain again afterwards.
Yeah. And then so
look
pressure,
at the difference. Yeah.
This much I can endure before I find it too painful.
Yeah.
Then I do something, and what would be the usual finding if it was, say, on a 0 to 10 scale? 0 is no pain, 10 is the most pain you can imagine. And before cycling, pressure will be an equivalent of maybe 4. Would it then be higher or lower in people with fibromyalgia after doing cycling?
Yeah, so often we would see that people with more widespread pain would have less. They would need less pressure before it became painful after exercise. So they would
this is tricky. I also came wrong. That's why I was stumbling a bit about it. So let's just do this over, because thank God it's not live.
Yeah.
So what happens is you invite someone in, and let's use temperature because it's easier to talk about that way. So you say, how does this feel? And you give them maybe 50 degrees Celsius, and they say it feels like 8.
Yeah, so the pain level would be 8.
Yeah. Or you can say, tell me how much temperature I can put on your skin before it feels like 1 or 10.
Yeah.
So it's one or the other, right?
Yeah.
And then you do the exercise, and in healthy humans you would expect what?
That they would feel the temperature less painful, or that more temperature were needed before they would feel it as 1 or as 10.
And this is what we call exercise
In hypoalgesia.
Hypo meaning less painful.
pain.
So exercise in normal people would lead to them being less sensitive
to pain.
Something that's painful.
Yeah.
And is that the same in fibromyalgia?
No, so there we would often see that there would be either no effect of exercise or even the opposite, that they would become more sensitive, or that less pain would less temperature would actually cause pain.
So this is sort of a conundrum, because here in EFIC, for instance, we have the Move with Pain or On the Move campaign, which is basically telling patients to exercise, and you were saying that they might even get more sensitive. So how can that be?
Yeah, well, I guess that most of the patients we also talk about exercise with have the experience of more pain either during exercise or after exercise. So I think it's a very well-known clinical phenomenon that exercise can also induce pain or cause pain. And in especially the patients we see who have pain in most areas of the body, or are quite sensitive, that would typically be the response. So that exercise does not have the acute or the fast hypoalgesic or pain relieving effects, but typically the opposite. So you might say, well, why should you exercise then? First of all, the acute response you have to exercise is not necessarily identical to the response you will have over 12 weeks. So it may be that once you expose yourself to something in the beginning, you may have one response, but that may change over time. So it does not necessarily mean that you should not exercise, but it may mean that that what will happen initially is different than if you did not have pain.
Yeah. So it could be maybe different trajectories. So you could either have the same level of pain when you exercise, or you could have even more pain or less pain. But what you're saying is that over time that could change?
That could change, yeah.
And of course, it's great if you maybe have a bit more and then it goes down and you are having less pain after exercise. But would you say that someone should exercise even if they have more pain?
Well, I think that the studies we have does not necessarily translate directly into clinical recommendations for whether you should do it or not. But I think from the knowledge we have that in the long run, being active, moving, especially reducing inactivity, do have some positive effects on some of the consequences of pain, and it may also be able to reduce pain in some people. But I think it's especially the more non-pain related effects that's important to consider, such as health, physical health, mental health, quality of life. So there may be reducing the risk of getting other comorbidities like heart disease and stuff like that. So I think the arguments for exercise is not only pain related, but I think the fact that exercise may increase pain may be one of the barriers to actually having an active lifestyle when you are in chronic pain.
It's pretty much more about removing barriers than actually having pain-free exercise. And honestly, I think most of us will feel that exercise is somewhat uncomfortable, wouldn't we? Which
and
is of course not the same, and I understand it's completely different, but I understand the barrier in exercising. But you were here at the Congress because you've given a talk in one of the sessions, which was on exercise and pain, and we've previously invited Professor Mira Moos to speak about her talk. Could you invite us into what were your findings and your research?
Yeah, so I've primarily been focusing on looking at similarities between the response after exercise. So how does it affect your perception of pain, and how that is similar or maybe different to other ways we can modulate or change people's perception of pain. So I've primarily been looking at the conditioned pain modulation paradigm, where one painful stimulus will change the way you will feel another painful stimulus. So I've been interested in looking at whether an exercise has similar effects.
And so we've had several interviews here, including Professor Kirsty Bannister from King's College London, who have been telling us about how the brain can actually send messages down that can then inhibit or transduce or modulate signals coming in. And we traditionally have used this to explain how maybe acupuncture works or how some medicines work, but you're suggesting that this could also be the same system, but maybe in a different manner?
Yeah, at least my interest was in whether that was how exercise was actually working, because we know from quite a few studies that people who have pain may respond different to other painful stimulus. So the experience that exercise had the same effect, that some people were actually not responding in the way we would think they should,
or the way normal
that people that do not have pain response, that there may be an overlap with those systems.
And what I think you're saying is that the idea was that exercise would trigger this system, if that's true, then everyone would feel better after exercise, and we sort of have an idea why.
Especially if that system was working as it should. Yeah.
And is that the case then?
Well, I think what we see is that if exercises are painful, they may be more efficient, especially if you don't have pain. So part of the response, part of the positive response of exercise on the acute perception of pain is probably related to activation of some of these systems.
Yeah. In healthy people.
Yeah. And it also looks like that if this system is not working, or at least that we cannot activate it by other protocols like the conditioned pain modulation, that patients who don't respond like that also have another response to exercise. So they do not have the positive hypoalgesic effect. So there may be an overlap of these mechanisms. It also looks like if you are very effective in activating these systems, you also may tend to have a better effect of exercise.
Would that be like an elite sports person?
Not necessarily, but some people just have a large pain reduction. And if they do have that, when we test them, for example, by placing a hand in cold water and activate these descending systems, they also tend to have a larger effect from exercise. So there appear to be some overlap in some way.
Yeah, so what you're saying is if we do the temperature and we ask you to tell me when it hurts, and it hurts at 45 degrees, and then I put my hand on my foot in ice water, and you burn me again on the other side, then I should go to maybe 47 degrees, so 2 degrees more.
Yeah.
And we call that the CPM effect, the conditioned pain modulation effect. And in that's what we would see also, not if they put their foot in ice, but if they go on a bicycle and they don't have pain.
Yeah. So there would be a relationship between the two responses. So people who tend to have a larger response with the hand in cold water would typically also have a higher response.
How does that inform clinical practice?
Well, it might make you think that exercises has to be painful to be effective, and I think that has at least triggered the idea that some of the reason why people do not respond to exercise, why we may see barriers, is that exercises have not been performed correctly or in an adequate stimulus. So I think that was some of the idea behind that. But when we look at it in patients, it doesn't look like it has that relationship anyways.
So it seems reasonable that if in healthy people more painful exercise gives more pain reduction, then people in pain should be doing painful exercises.
Exactly.
But you were just telling us that pain is a barrier as well.
Yeah.
So it turns out that maybe they shouldn't be doing all this painful exercises.
No, so at least what we can see is that if people, for example, exercise in areas where they have pain, they do not have a positive response. But if they exercise in areas where they do not have pain, they may be able to trigger a reduction in how they feel pain.
And speaking of reduction, if I reduce this down, there's, you can look at the internet, if you look Google pictures and you say pain, there would be a sign saying no pain, no gain.
Yeah.
But what you're saying is if you are already in pain, say in your knee, and you exercise that knee, then more pain is not going to necessarily mean something beneficial for you in terms of reduced pain as well?
No, at least the acute response to that exercise in the knee, you might expect an increase in pain immediately after.
Yeah.
But if you exercise in other areas of your body, it may actually be possible to trigger a reduction in pain, so you may be less sensitive to
and
pain.
then over time that might change?
Yeah, it might change, but it may also be a way of helping people to move, helping people to do exercises in areas that is not painful. So it may reduce some of the barriers to being physically active. And it may also have a positive effect on how we perceive pain.
So if everything hurts and you want to get started by moving, then your research would suggest that doing non-painful exercise would be a great way to start?
And possibly in areas of the body where you don't have pain, if that is possible.
And you can access, or you can exercise as much as you like. Would it be okay if they got sore after exercising? So these muscle type exercise type pains?
Yeah, so that is very common. So exercise can reduce pain, but exercise will also often induce pain. So soreness afterward is quite normal, and it's not a barrier necessarily. But of course, if your impression of what is actually causing this soreness, is it a good thing or is it a bad thing, that may impact on your adherence or your compliance or your motivation to keep on moving if you are not really sure whether this is a good thing or a bad thing.
I know your clinical background comes to play here, because what you're saying is that even though we look at something and the data seems very solid, then by the end of the day it's about the patient, isn't it?
Yeah.
And this is one mechanism that you can study and that you find some great data related to. But it doesn't necessarily explain what everyone should do.
No.
So it might explain what some people can do. And I also hear you say that it's legit for some people to say, it really hurts me when I move. Could I do something else? And then the clinician could say, okay, I can help you remove barriers by moving a different body part or graded exposure to movements that might be painful so that you over time can get less painful.
We have a very recent study that also where we also observe that it's very important that people believe in what they are doing in terms of exercise. So involving the patient in what exercises would you believe would be beneficial for you, and not necessarily doing stuff that feels uncomfortable or doesn't feel right, or where the patient is uncertain whether this is good or bad. So moving appears to be good. It appears to be better if it's not happening in a painful area, and it doesn't have to be painful. So there may be approaches that may help people move if some of these things are barriers.
Yes, and I hear you say that it goes along with education and advice and
knowledge about
and feeling comfortable as well, basically, isn't it? So if I was a patient, I was listening to you right now, I would say, okay, so it might not feel less paining or painful when I move, but it's still good for me. But what I should do is definitely feel safe about it. So if I'm in doubt, I should talk to someone. Is that sort of what you're saying?
Yeah, that could be an idea. I think it's of course important to feel safe, but you should also feel that this makes sense or has meaning.
Yeah.
So and be something you believe would be good for you.
Yeah.
So sometimes it may be relevant to consult someone if you are uncertain whether this is good or bad or right approach. But I think if in general terms we know that moving is not dangerous. It's very rarely doing anything bad. So in most cases it will be safe. So if you believe in it and expect that this is going to help you, that is a very good start. It doesn't have to hurt. It doesn't have to be in the area where you have pain. It doesn't have to be for very long. The first step and just doing a little thing is probably quite important here.
That's fantastic. Yeah. I understand why your talk was such a success. Thank you very much. Is there anything you want to add before we stop?
No, I think we've covered it pretty well.
Thank you very much for seeing us.
And thank you for inviting me.
Cheers.
Cheers.